Few more seconds to go, but almost there. Dear colleagues, welcome to our monthly dialogue. This is a very special dialogue because it's the last dialogue for this year. And as you know, we never stop. We don't have holidays, we don't have Christmas, we work all year long. And today is a good opportunity because during this last dialogue for 2022, the intention is to look back at an inspiring year at the European Heart Journal. And in order to celebrate this last dialogue of the European Heart Journal, we have a special panel of guests for this dialogue. And our guests are editors of the European Heart Journal. You can see with me Lale Tokgözoglu, Tybjærg-Hansen, Lina Badimon, and Cecilia Linde. And the dialogue today will be with these wonderful editors of the European Heart Journal. And again, the intention is to look back at the interesting papers we have published during this year and the interesting initiatives we have taken at EHJ in 2022. I will ask our editors to give their perspective based on the interesting papers we have published in their field of interest in the last 12 months. And then, of course, will be also discussion about the new features of the journal, what are our plans for the future, what we have been learning from the past experience, a window on the European Heart Journal. But let me start with Lale Tokgözoglu. She's professor of, she's deputy editor of the journal and professor of cardiology at Ankara University. And she's been president of the European Atherosclerosis Society. Lale, my question for you, and the same question will be also for the other editors. What are the papers you found most interesting in the last 12 years? In your case, in particular, in the field of dyslipidemias. Please, Lale.
Thank you, Filippo. Good evening, everyone. It has been an exciting year in lipidology where novel pathways for lipid-lowering therapy have been targeted with new agents and nucleic acid-based therapies. So I'd like to point out 3 papers that we published in the European Heart Journal that I thought were interesting. The first one is the consensus paper of the European Atherosclerosis Society on Lp(a). Now, the contribution of elevated Lp(a) to cardiovascular risk is underappreciated, despite the fact that 1.4 billion people worldwide have elevated Lp(a) levels. So just a few major points from the consensus. First of all, new evidence points out that there is a causal and continuous association between Lp(a) and cardiovascular outcomes, as well as aortic stenosis. Lp(a) levels above the 75th percentile increase the risk for aortic valve stenosis and myocardial infarction, above 90th percentile heart failure, and above 95th percentile stroke and cardiovascular death. We know that Lp(a) is pro-inflammatory and pro-atherosclerotic, but the role of Lp(a) in prothrombotic and antifibrinolytic activity in vivo is unproven, and the consensus document stated that it does not increase venous thrombosis. The consensus statement said clearly that ideally, Lp(a) should be measured at least once in adults in a lifetime because it's genetically determined and does not really change too much. It increases a little bit after menopause. However, the measurement is challenging and there's a substantial variability in assays. So ideally, we should be using an antibody for a unique epitope in ApoA, recognizing Lp(a) in each particle, and report the levels as nanomole per liter. The fourth point is that the association is continuous even at low LDL levels. So it's not safe just to lower LDL. We need medications to lower Lp(a) as well. And in the absence of specific drugs that lower Lp(a), we should at least try to modify all the other risk factors, lower LDL as much as we can. And in very high levels and high risk recurrent cardiovascular event patients, use apheresis. But ongoing phase 2 to 3 trials with nucleic acid-based therapies, small interfering RNAs, and antisense oligonucleotides are very promising and showing that Lp(a) can be lowered up to 99% with some of these. So there's a lot of hope for the future if these trials come out to be positive. So I just wanted to pinpoint a few important points about the consensus paper, but I would recommend that you read the whole paper because I'm sure there are a lot of other details that need to be taken into account. Maybe Anne would like to add something I missed.
Anne, please, unmute.
Well, I think you pretty much summed it up. The current consensus document has changed a lot, I think, from the 2010 consensus document. Could you highlight a little what the main differences are from that?
I think the fact that we know that it does not increase venous thrombosis is important. That's number one. The second is that now we recommend it to be measured once in a lifetime in everyone. Of course, those with an early, premature cardiovascular disease, family history, etc., are more at risk, and those with familial hypercholesterolemia tend to have higher Lp(a) levels. But having it measured once in a lifetime is important. And the third one, which is more in detail in the supplement, is the fact that as the total risk of the patient increases and as the Lp(a) increases, the increase in risk is significant. Now, in the guidelines, we say that the C statistics is not too high when you add Lp(a), it's just a risk modifier. But when you look at very high levels of Lp(a) and very high levels of risk, there's a huge risk increase showing that there is a need for Lp(a) specifically lowering agents. I think these were the major differences. There's also a part saying that very low levels of Lp(a) may increase diabetes risk. We're increasingly seeing the signal in different studies, but we have no idea what the mechanism is yet. So I think these were the points that were the major changes.
Thank you. This is a very important position paper, which is already very well cited. Also because there's growing interest in lipoprotein little(a), probably because now we have new forms of treatment. The doctors become more interested if something not only can be described, but also treated. One short question, what about Lp(a) and aortic stenosis? Because this is another growing field of interest. We failed with statins in the past, but probably was the wrong target with drugs given too late. What are your feelings about Lp(a) and aortic stenosis?
There are interesting studies like the Rotterdam study and others looking whether the experience from the group in Copenhagen, whether it increases risk, B, whether it increases progression and calcification. Now, it does significantly increase risk if the Lp(a) is above the 75th percentile. But whether we can modify it after the aortic valve has become calcified is a big question mark. And probably, just like LDL, not possible. So I think it's important to detect elevated Lp(a) early on in life.
Thank you, Lale. I remind the audience that this is a very interactive dialogue. These webinars are very interactive, and it's not just a chance that we call them dialogues, because we want dialogue not only among editors and others, but also with the audience. By the way, I want to mention that I see Peter Libby in the screen. The idea of calling these webinars dialogue came from him, and was really the most appropriate term to use for this initiative. Of course, this term was very welcomed by Panos Vardas, because clearly it's a Greek word, but really it's been a successful suggestion. Now, and I remind you that these dialogues are interactive, so you can ask questions in your chats, or you can raise your virtual hand, and we will involve you in the discussion. Lale, can you summarize for us your second paper, the second most interesting paper you found in our journal during the last year in dyslipidemias?
Yes, I think prominent was a landmark trial that was published this year, showing that lowering triglyceride-rich lipoproteins with PIMA fibrate failed to reduce cardiovascular events. So we're still left with residual triglyceride-rich lipoprotein-related risk in some patients, and we don't know what to do with it. Now, ApoC3 is thought to be proatherogenic and a key regulator of triglyceride levels. And we know that individuals with loss of function mutations of ApoC3 have reduced atherosclerotic vascular disease. So one interesting randomized trial we published this year was about olezarsen, which is a third generation antisense oligonucleotide to inhibit ApoC3 production. In this phase 2b randomized, double-blind, and placebo-controlled trial, 110 patients were randomized to olezarsen or placebo. This was an ascending dose study, so doses from 10 to 50 milligrams were given, and there was also a placebo control. All these patients had either atherosclerotic vascular disease or high risk. And at the 6 or 12 months later, triglyceride and lipid levels were measured. At the end of the trial, olezarsen resulted in a significant mean percent triglyceride reductions, up to 60%, which was dose dependent. And furthermore, other atherogenic lipoproteins, such as non-HDL and ApoB, were also reduced, and LDL cholesterol did not increase. So this was slightly different than what we saw with PIMA fibrate. Furthermore, because this is a third generation medication, unlike volanesorsen, which caused thrombocytopenia, there were no platelet count, liver, or renal function changes. So these findings suggest that inhibiting ApoC3 can be a potent approach to lowering triglyceride levels, and may in the future, if the trials come out to be positive, decrease pancreatitis risk as well as cardiovascular risk. But we have to see the outcome of the larger trials, because this was just a modest size phase 2b trial.
Thank you, Lale. This life beyond LDL cholesterol. I mean, what we are learning is that there's a residual lipidic risk we cannot ignore. And this is one way to face this residual lipidic risk. Questions for Lale from the other editors, Anne in particular, Lina, Cecilia, do you have questions for Lale on this very important paper? Please, Anne.
Yeah, so could you elaborate a little on the triglyceride lowering trials so far, and what they have shown, and why you think they have shown what they showed?
I think that you contributed a lot to literature about the importance of remnants and triglyceride-rich lipoproteins. And We do believe that remnants, VLDL and IDL, are atherogenic. Actually, all the ApoB containing lipoproteins have the capacity to be captured by proteoglycans and increase atherosclerotic vascular disease. But to decrease the risk related to them, the prominent trial also taught us that we have to go all the way. Reducing VLDL or triglycerides is not enough. We also have to take down and lower ApoB levels and LDL cholesterol levels, which was not the case in the prominent trial. So we need to clear all of them, it seems, to have a cardiovascular benefit, because obviously they're pro-atherogenic. So maybe we're moving a little bit away from LDL cholesterol to non-HDL and ApoB cholesterol if we want to capture all the atherogenic lipid-related risk.
Thank you, Lale. Well, now let's move to the third most interesting paper you found in our journal in the last year.
Yes, I think that another landmark important trial was the Fourier open-label extension study performed this year, demonstrating that lowering LDL cholesterol by PCSK9 inhibition, in this case monoclonal antibodies, was very safe and very effective. And at the end of 8.4 years, with a median LDL of 30 milligrams per deciliter, the patients benefited and there was no harm. So since the success of monoclonal antibodies targeting PCSK9 with different tools to lower LDL cholesterol are being explored, and inclisiran is a small interfering RNA which can be administered only twice yearly to reduce LDL cholesterol. Now, whether lowering LDL cholesterol with inclisiran translates into lower cardiovascular risk is not currently known. And we will know this when the Orion 4 and Victorian trials are published. But we know that the patient-level pooled analysis of Orion 9, 10, and 11 studies included about 3,655 patients with atherosclerotic vascular disease, risk equivalent, or heterozygous familial hypercholesterolemia. And this pooled analysis treated patients who were maximally tolerated statin dose with inclisiran. And patients were randomized to receive either placebo or inclisiran on days 190 and every 6 months thereafter. There was a pre-specified endpoint of major cardiovascular events in this pooled analysis. And this year, in our journal, we published the results of this specific endpoints. The LDL cholesterol reduction was about 50% with inclisiran in this pooled analysis. And interestingly, the major cardiovascular events were reduced by 26%. Of course, this is just a patient level analysis of phase 3 trials, but this offers us early insights in the potential cardiovascular benefits of lowering LDL with inclisiran. There were no safety signals or no major side effects except for injection site reactions and bronchitis in some patients. And while these findings await confirmation in larger outcome trials, I think this current analysis is interesting and should be considered as hypothesis generating.
Thank you. Growing interest in inclisiran, really a new window that you are opening. I see many questions from the audience already. One short question. What about the effects of these different anti-lipid treatments on CRP and inflammation? Long ago, Peter Libby and Paul Ridker showed that statins reduce CRP levels. What about these new forms of treatment? Briefly.
We know that bempedoic acid and icosapent ethyl significantly lower high sensitivity CRP. And of course, there are upcoming agents that are directed specifically to target inflammation. For example, the ZEUS study is exploring the effects of ziltivekimab that is specifically going to lower high sensitivity CRP. but PCSK9 inhibitors do not significantly reduce high-sensitivity CRP.
Thank you, Lale, for your clear and concise reply. And now we move to another editor, Professor Anne Tybjærg-Hansen. She is a professor of cardiovascular biochemistry at Copenhagen University. She is executive editor of the European Journal, and she has been the recipient of the Anichikov Prize given by the European Atherosclerosis Society. And please note that this prize was given to Anne by Lale, at that time president of the society, and Lina was in the committee for this prize. But please note that this was before their involvement with the European Journal. So, but really, it was a remarkable premise for their involvement in our journal. Anne, your favorite papers in the last year?
Yes, thank you, Filippo, and hello everyone out there. We receive a lot of excellent papers, so it's very difficult to choose papers. So what I have done is I have chosen three very different papers, actually. The first paper is called Elevated Remnant Cholesterol Increases the Risk of Peripheral Artery Disease, Myocardial Infarction, and Ischemic Stroke, a cohort-based study. And the first author was Benjamin Wadström, the senior author, Borg Nordesgaard. So what they ask in this study is they ask whether remnant cholesterol is associated with increased risk of peripheral artery disease. We already know from the previous studies that remnant cholesterol, increasing remnant cholesterol, is causally associated with risk of myocardial infarction and also with ischemic stroke. They used two prospective cohort studies, the Copenhagen General Population Study, which was the primary study with about 107,000 participants recruited in 2003 to 15 with about 9 years median follow-up. And as the validation sample, they used 14,000 individuals from the Copenhagen City Heart Study recruited way back in 1976 to 78 with follow-up examinations every about 10 years. The diagnoses were from Danish registries, which are very complete. So we have, so there is complete follow-up here of all participants. What they did was then that they compared elevated remnant cholesterol in a stratified manner. So the reference group was those who had levels below 0.5 millimoles per liter, and then with increasing levels up to at or above 1.5 millimoles per liter. And then looked at prospective risk of myocardial infarction, peripheral artery disease, and ischemic stroke in these two different population studies. And what they found was that peripheral artery disease was associated with a fivefold increase that remnant cholesterol was associated with about a fivefold increased risk of peripheral arterial disease in both studies, and with significant but lower risk of myocardial infarction and ischemic stroke, around about 2.5-fold, 6-fold increased. So this shows a novel association. Of course, it's observational with remnant cholesterol in two large studies, and it of course questions whether peripheral arterial disease should not be an endpoint, which was looked at in randomized clinical trials of triglycerides, which are markers of remnant cholesterol in the end.
Thank you, Anne. Very, very interesting study. Comments from the editors? My question is about what about the therapeutic implications of these observations? What do you see in your crystal ball?
Well, if you find that peripheral that this is a causal association, then the obvious thing would be, of course, to treat the triglycerides. But I think the problem is that we don't have any evidence so far from randomized clinical trials that is going to have any effect, except for in REDUCE-IT, where there was a reduction, in this case, in cardiovascular events with icosapent ethyl, but the reduction in triglycerides was disproportionate to the cardiovascular risk reduction. So there's something else going on there. So, I mean, we'll have to see what some of the novel trials, ApoC3 inhibition, what they are going to show, actually.
So again,
but the risk here was significantly higher than for other endpoints.
So again, back to residual lipidic risk, triglycerides and LP(a) and perhaps HDL. I wonder whether in the future back to HDL. I mean, there are residual targets really to consider. I find another interesting comment, a question from the audience. By the way, the first question was asked by Dr. Ramadan, and I can read another question from Dr. Perk, and the question is about postprandial triglycerides. Do we need to pay more attention to postprandial triglycerides?
Yeah, well, in most of the time we are actually postprandial, except just before the meal in the morning, I guess, just before breakfast. So since 2009, at least in the Scandinavian countries, we have not measured triglycerides fasting because it doesn't make any sense.
Thank you. And you also had the second paper to discuss.
Yeah. Mm-hmm. The second paper is one of my newer interests, I'd say, and it's called Characteristics and Natural History of Early Stage Cardiac Transthyretin Amyloidosis. So it deals with the specific cardiac amyloidosis due to transthyretin destabilization. Now, this paper focuses on early stage cardiac transthyretin amyloidosis, which I think until recently was never diagnosed, because this is a very, very underdiagnosed disease probably. But what they look at here is early stage transthyretin amyloidosis, and this is defined as National Amyloidosis Center transthyretin amyloidosis stage 1. And this is characterized by an NT-proBNP at or below 3,000 milligrams per liter and an estimated glomerular filtration rate at or above 45 milliliters per minute per 1.73 square meters. And they then take these individuals with the early stage amyloidosis and divide them into type 1A and type 1B. The most severe is type 1B. Type 1A is characterized by loop diuretic equivalent treatment to furosemide below 0.75 milligrams per kilo and an NT-proBNP at or below 500 nanograms per liter, or if the patient has atrial fibrillation, at or below 1,000 nanograms per liter. And in stage 1B, of course, the furosemide equivalent is higher than the 0.75 milligrams per kilo, and the proBNP is also higher. And they then move on to look at, among other things, mortality in these two groups, and show that mortality over, I think it's 100 months, yes, 100 months, is actually not increased in type 1A, but is increased in the type 1B group. And in fact, in the type 1A group, they have the same mortality or similar mortality to age and gender matched controls in the background population. The study is from UK. However, even in the 1A group, we see that the disease becomes more severe, actually, as measured by a number of parameters, suggesting that with a longer follow-up, this is not going to go well, actually, even in that group. So the discussion here is whether you in these individuals with type 1A, whether they are actually eligible for stabilizing thyroxine treatment, even though they do not die more over a short period of time. And I think this is an excellent paper. It's very well presented, and it raises a very important question also. And it would be nice if we had some way of diagnosing this disease long before they actually get cardiovascular disease, because we know that there are red flags that eventually will lead to this.
Yeah, I agree. This is a very interesting paper, also because treatment with tafamidis is given to patients with more advanced disease to be staged, while this data suggests that it might be worth starting at an earlier stage, but of course we need evidence from trials. Now I'm reading a comment from Raul Santos. The comment is lipids role. Now wait, be patient. Lipids are very important, but now in a moment we will move to heart failure with Cecilia. But I have a last questions for Lale and Anne from the audience. Dr. Enrique Sanchez Delgado, and the question is how soon to start inclisiran? Very, very soon, very, very early, as suggested by Professor Braunwald. I think it's an intriguing question. What are your gut feelings about starting very, very soon?
So if I may, we know that LDL cholesterol is not only causal, but cumulative. And starting very early on to reduce LDL cholesterol will go a long way. And you don't need to make huge reductions in LDL cholesterol if you start very early on. Professor Brian Ferencz has a very good modeling, which he proposed, and I think he talked about it in the previous ESC meeting, where if you reduce LDL cholesterol starting from the age of 30 with once a year inclisiran, then you can postpone the accumulation of LDL cholesterol to such an extent that you can completely change the trajectory of the disease and postpone cardiovascular events. So this is a very attractive hypothesis, but needs to be proven. But for sure, we should start lowering LDL as early as possible. First of all, we need to detect familial hypercholesterolemia as early as possible. And these patients will be the ones to be most benefiting from early treatment. But otherwise, with lifestyle modification, the earlier, the better is our motto these days.
Thank you. Lale, Anne, any further short comments?
No, well, a comment could be that how do we get the pediatricians to treat the children with FH earlier? I mean, in my country, I think they're not really treated at all, basically.
Really, it's a new window we have opened, definitely. Now, before moving to Cecilia, I have a strong temptation. Temptation is too strong, and as usual, I cannot resist temptations. The temptation comes from a question from Dr. Miao Wang, and the question is not related to lipids, but the question is, what are the hurdles before anti-inflammation becomes a treatment? And I see Peter Libby there. Peter, I cannot resist the temptation. Can you address this question? What are the hurdles before we can use anti-inflammatory treatments?
Oh, well, thank you, Filippo. But as Lale already mentioned, there is an ongoing phase 3 trial with an anti-IL-6 agent that we hope will avoid some of the reduction in host defenses that one sees going one step higher in the pathway of inflammatory signaling from inflammasome to IL-1 beta, IL-18 to IL-6. So the phase 2 data show profound decreases in C-reactive protein, over 90% of the highest dose tested. And so let's see what the outcome trial shows. That's the ZEUS trial that's being led by Dr. Ritker, as Lale mentioned. We have colchicine, but colchicine also has some signals for potential harm, maybe even mortality signal, and is something we don't want to use in our patients with chronic kidney disease, which certainly in my practice in the inpatient clinic, we see almost all of our patients have chronic kidney disease, some degree of renal impairment. So we do need an agent beyond colchicine.
Thank you, Peter. Professor Lieb is executive editor of the European Heart Journal. And now we move to another page, to heart failure. And it is my pleasure to introduce Professor Cecilia Linde. She's professor of cardiology at Karolinska University in Stockholm, and she's treasurer of the European Society of Cardiology, and importantly, she's executive editor of the European Heart Journal. She's the top expert in heart failure and electrical treatment of heart failure. Cecilia, please, what are your favorite papers in the journal in the last year?
Thank you so much, Filippo. Thank you for those fine words. So this is teamwork, and I can see Jan Bauersachs, who is also editor for heart failure in our journal, is online. So some of the choices I made actually come from the group of editors, and I would like to start with the GUIDE heart failure trial, because not only did we see that myocardial infarction rate dropped during COVID, but also heart failure hospitalizations. And the CardioMEMS device, which is a pressure monitor you can insert in the pulmonary artery, gives us some indications of why this may be. And the GUIDE heart failure trial implanted all their patients with this device, but hemodynamic directed therapy was only given to half of these patients, even though all of them transmitted their pulmonary artery pressures every day. And these were chronic heart failure patients, functional class 2 to 3, well treated. And during the era before COVID, there were twice as many adjustments of medications in those where the doctors could actually see the pressures that were transmitted, mainly adjustments of diuretics, thiazides, beta blockers, etc. And that was also liaised with a drop in heart failure visits and hospitalizations, which was significant. But then came COVID, and surprisingly then, the rate of events dropped in the control group and remained the same in those with hemodynamically guided therapy. So something happened in the control group, and there were in this period very well compliance with sending in the pressures. They remained low in both treatment and control group. The adjustment medication became less in both groups, but somehow, and there were no signs of disease progression or regression in any of the groups, but somehow there were less events in the control group, despite that they didn't have hemodynamic directed medication. And it can only be speculated what the reason was. And that the authors do speculate that maybe it's because of you stay at home, you don't eat so much junk food that is rich in sodium, and sodium of course retains fluid, increases filling pressure. Another thing that I thought about in HFrEF is perhaps they ate a little bit better, more and had a better nutritional state. And another possibility is that they were more compliant to the heart failure medication, but actually we do not know. But it would be very interesting to know what is the reason, because that is something that we can take with us in our daily heart failure therapies. And then if we only knew what that was, we wouldn't need to implant any pressure monitoring devices. So I think this is an intriguing study, and it just reveals how little we actually know about heart failure. That was a very good study, in my opinion. And then, of course, we had openings for heart failure with preserved ejection fraction therapies that we didn't have before the last year. And in a publication by Javid Butler, who is also an editor in our heart failure team, they did a meta-analysis that of almost 10,000 patients, both with the EMPEROR-reduced study, empagliflozin in heart failure with reduced ejection fraction, meaning below 40%, and heart failure with preserved ejection fraction, EMPEROR-preserved, which was defined as ejection fraction above 40%. And they could demonstrate that all over this panorama of ejection fractions, the worse ejection fraction you had, of course, you had more heart failure hospitalizations and morbidity. But nonetheless, over the entire spectrum, there was a 30% reduction in events by empagliflozin compared to control, with the possible exception of those with a very high ejection fraction. Was a small group here with EF above 65%. So to make it simple, it just means that this is a medication that seems to work over the most or the entire spectrum of ejection fractions. For clinical practice point of view, you don't have to wait to have an echocardiogram before starting the medication, and it's a one-dose therapy, not much in terms of side effect, and it's really good news for heart failure patients. Then you may speculate why this smaller group with ejection fraction above 65% didn't seem to derive a benefit. And there you can only speculate that this was in a different group of patients, elderly females at atrial fibrillation, not so elevated into pro-BNP, and that may have been other mechanisms for their disease that wasn't treatable by SGLT2 inhibitors. And let me just add here, there's been another meta-analysis on DAPA, basically doing the same thing, taking the DAPA-HF and the DELIVER trial, so that they also had the entire range of ejection fractions, and there was no p-value of interaction amongst the ejection fractions. So that study did say that the drug dapagliflozin worked over the entire range of ejection fraction, also those in the higher range. So let's see, it's an open question in those particular patients, or if it's a class effect that is explained by the different drugs. I do not know exactly. But I thought that was a very interesting study as well. So I don't know whether we should discuss this or if I should move to my last study of preference.
Yeah, go to your last study and then we open the discussion on this.
Yeah, okay. Yeah, it's been said that because of hyperkalemia, many patients cannot receive guidelines indicating a medication such as ACE inhibitors or MRAs. And if you do reduce or even discharge such medication, it can be potentially life-threatening. And now we have two different substances commercially available that lower potassium, and the DIAMOND trial assessed one of them, patiromer, in chronic heart failure. And this is a publication by Javid Butler, and it's called Patiromer for the Management of Hyperkalemia and Heart Failure with Reduced Ejection Fraction, the DIAMOND trial. And it included patients who either had hyperkalemia above potassium above 5.5, or had a history of having reductions in these medications due to hyperkalemia. And all of these patients were put on patiromer for a run-in phase. And during that time, 84% could achieve at least 50% of the guideline indicated dose of ACE inhibitors. And most also could have at least 50 milligrams of MRAs or eplerenone. Following this run-in phase, this established that patients could tolerate patiromer. They were randomized to either keep the drug or have it discharged, and then followed some 25 weeks of study period with a potassium level as the primary outcome, and then potassium-related events and changes in medications as other outcomes. And what the study showed was that indeed, if you are kept on patiromer, there is a lowering of serum potassium level, not very much, in my opinion, 0.10 millimoles per liter. That's not terribly impressive, but there were significant benefits in that there were less hyperkalemic events, less need to reduce or discharge MRAs, and less recurrent hyperkalemia. So there were indications that this may be a drug of value in certain circumstances. But then that paper was followed by a, let's say, little bit pertinent editorial with Milton Packer, in which he questioned the entire concept, because he said that actually it's not been shown that you need as the maximal dose of MRAs for mortality reductions. So 50% of spironolactone may not even be needed. And if you take that aspect into account, it's very, very expensive to prevent one hyperkalemic event by using patiromer. So let's just say it remains to be established what this regimen will lead to in terms of cardiovascular morbidity and mortality, which was not the topic of the DIAMOND trial, and if it's cost efficient to reduce potassium with a drug like patiromer.
Thank you, Cecilia. Regarding this last paper, the patients in the trials, in addition, were not on gliflozins, and we now know that gliflozins reduce the risk of hyperkalemia. So putting together all this data, perhaps Milton Packer was right in his crispy comment, writing that he doesn't see so much future for this new class of drugs. But the time will tell. Well, I see in the audience Professor Johan Bauersachs, who is our deputy editor for heart failure. Johan, any questions and comments for Cecilia about these three papers?
Cecilia, you did an excellent job in summarizing these three important papers. Perhaps one comment regarding the EMPEROR pooled prevention of hyperkalemia. We had this also in the journal as I think, a pertinent paper, that hyperkalemia is prevented to some extent by SGLT2 inhibition, especially with empagliflozin, but similar data is also there for dapagliflozin. So my question perhaps would be, there was also now a recent paper in Nature Medicine working again out these different ejection fraction subgroups in EMPEROR preserved, and there it turned out that there may be not a difference between DAPA and EMPA, and that also above 60% EMPA should work. So I think, in my view, there is no difference between EMPA and DAPA, and you can give them all for the whole spectrum of ejection fraction. What is your impression when you see the whole bunch of evidence?
Yeah, I would actually agree with you, and I think it's very good that it's clear, because what we want is the patients to have therapy, and as soon as these kind of discussions start, there is reluctance, and that some patients will not get therapy, perhaps many patients who actually will benefit. So I think you're absolutely right.
Thank you, Cecilia. Also interesting, the initial paper you presented during COVID, heart failure patients improved their parameters. So something to learn from bad experiences. COVID has been dreadful. We went through 2 really very difficult years. Now we are back to life, and it's a great joy for all of us. But yeah, still something to learn from COVID. Perhaps less physical exercise during COVID.
No, I think we also had used hemodynamic monitoring in the Karolinska, and we did demonstrate that these salty menus like Chinese foods and pizza, or in the Scandinavian countries, crayfish, herring, those kind of celebrations actually exacerbate elevation in pulmonary artery pressure and acute heart failure deterioration. So my personal take on this, that it was good not to visit any of those places or have that kind of food.
Thank you, Cecilia. Well, in the audience, I see a young and promising cardiologist, Bernard Gersch. Hi, Bernard.
Hi there.
you unmute yourself. Well, Bernard is co-editor of the European Heart Journal, and this is really a wonderful person, incredibly knowledgeable in all fields of cardiovascular medicine. Bernard, any comment or question for Cecilia?
Am I unmuted now?
Yes, please, we can hear you.
Well, I'm glad to hear that I'm promising. I'm not so sure about your description of me being a young, promising cardiologist. Now, I really enjoyed Cecilia's presentation. I loved the Packer editorial, as I always love everything that Milton writes. And, my only real comment about the mineralocorticoid inhibitors is to go back to the original TopCat trial, which was a landmark. And I was on the data safety monitoring board of that. And we learned a lot of lessons about that trial and actually published it in a paper with Mike Bristow. But I do think that the benefits of the mineralocorticoid inhibitors are underestimated and underutilized. And so I'm not sure whether the potassium lowering agents will or won't be effective, but I'd really like to see, I really do think that this is a key part of heart failure therapy and underutilized.
It's also one of the easier drugs to give to patients if you work in a heart failure ward. I'm sure Johan will agree with me. I mean, it's the SGLT2 inhibitors, the MRAs, no problem. What causes problem is actually drugs like ARNI and beta blockers, where you have to be a little more careful depending on blood pressure, heart rhythm, etc. But I think what the point you wanted to make is really, do you need to reach a target dose? Is it enough with just 25 milligrams? That he based on the Editor-in-Chief trial and on the RAS trial.
Do you think we'd ever get an answer to that? I mean, I don't see anybody doing a trial of that particular question.
Well, if you go with one step forward and go to the strong heart failure trial with Alex Membasa as the main author, apparently you can give maximal heart failure medication really quickly over 3 weeks' time in many patients. So I think it's very much a matter of how we structure our heart failure care, and that particularly we do not discharge patients and not follow them very soon so that we can adjust things quickly. And then we end up with 25 or 50 milligrams, I don't think it matters as long as we have these 4 drugs, potentially also with a little bit of CRT for those indicated.
Well, we have this, as defined by Johan Bauersachs in his editorial, this magnificent 4. Now we have to learn how to use them in the best possible way. They are there. How to use is something we keep learning. Thank you, Cecilia, for your presentations. And now we move to Professor Lina Badimon. She is Professor of Cardiology in Barcelona, of course, Executive Editor of the European Heart Journal, and past Vice President of the European Society of Cardiology. And Lina will tell us about translational papers published in the European Heart Journal. We pay a lot of attention to translational papers, but they become interesting for the journal if they have a high translational value, if they identify new potential therapeutic targets. So keeping in mind that we publish translational papers and not basic science papers, Lina, please tell us about the 3 papers you most enjoyed in our past year.
Good afternoon for our European colleagues and friends, and good day for the rest. I see many American friends that have joined us. So good day to everybody. Indeed. We are trying also to publish translational studies. There are not so many as clinical papers or epidemiologic papers in our journal, but we select those translational studies that provide new novel concepts, that also provide innovative approaches to understand pathophysiology. They have a strong translational outlook, and they have future clinical interest. So based on those concepts, we have had at least 1 translational paper in every issue published during 2022. I went through the papers that we published in this area, and really, obviously, they come from different areas of cardiology. I mean, there is research in the different areas of cardiology. I have chosen 3. It was difficult because there were many papers that were very important and interesting. But I have chosen 3 that I think are quite innovative. For example, the first one is a collaboration between Austria, Germany, and Canada, showing that it's important also this team effort to answer questions that are unknown at present. So I selected a paper by Dolexi et al. On adult T cell impairment of neonatal cardiac regeneration. So we know that upon myocardial infarction, neonat mammals, not only human, but also all mammals, can mount a regenerative response that results in complete cardiac functional recovery. And it doesn't work. I mean, there is a lot of scar formation, and this scar formation may eventually lead to heart failure. So what the authors did to investigate this question is to have neonate mice, and they have shown in these neonate mice that when they adoptively transfer adult T cells into these neonates, they blunt the myocardial regeneration that happens in neonate animals. So when these animals become adult, they lose their regeneration capacity, but what they have done is that in these very, very early neonates, they inject T cells, adult T cells, the regeneration is lost. Therefore, their study demonstrated that the perinatal loss of myocardial regenerative potential was associated with the emergency of the T cells immunocompetence. So when there is immunocompetence being developed in the animal as the animal grows. And this sheds light on cellular immune mechanisms that can be eventually exploited to really modulate the myocardial repair process. Obviously, this is a very early stage of research, but the results they show were very important, very important, because they did not only the analysis of the T cells that they were obtaining from adult mice and injecting in the neonates, but also did show the impaired cardiac regeneration versus the cardiac regeneration happening in the untreated animals. So they saw that the mechanism was dependent on interferon alpha. And they also show that monocyte-derived macrophages with CCR2 positive markers were involved in the process. So they not only show that this immunocompetence development of T cells was impairing cardiac regeneration, but they also found the signaling transduction and the mechanisms involved in this process. So eventually, this data into this physiological T cell development correlation with the loss of cardiac regenerative potential in these postnatal mice may suggest that we may have in the future possibilities of intervening at the level of T cells to recover this early PAPs potential for cardiac regeneration into older animals. So related to other immune cells in heart regeneration, the specific contribution of T cell subpopulations are really being investigated in this moment, because there are different T cell subpopulations, and they only isolated the whole T cells in the adult mice. Therefore, it represents another area of research where we can have information for trying to see if we can intervene to treat heart failure. This was the first paper I chose. The second goes into another area that is also of importance, and this is how do we treat cardiotoxicity. So this paper that I selected comes from a group of cardiologists and scientists from Germany, Singapore, and the Netherlands. The first author is Lu, and the proposal is that a circular RNA derived from the insulin receptor locus protects against doxorubicin-induced cardiotoxicity. This study is important because, as you know, the recent advances in anti-cancer treatment have led to a steady increase in the number of cancer survivors, enhancing the number of heart failure patients who suffer from the undesired cardiotoxic side effects of these anti-tumor treatments. So the therapeutic options to reduce or reverse chemotherapy, this chemotherapy-induced heart failure, are not available. There are no possibilities. So the authors look into circular RNAs. This is a type of RNAs that can be used to transfer them into drugs. So they have high drugability. Due to the high stability arising from the structure, these circular RNAs, they have a special closed loop structure. So this circular RNA that is derived from the insulin receptor locus, when we overexpress these circular RNAs, the authors show that they prevented doxorubicin-induced cardiac dysfunction in this model of preclinical disease that is murine. And also they have started to investigate human models with cells, isolated cells in a Petri dish. This circular RNA, insulin receptor locus, mimics reduced cardiomyocyte death under doxorubicin stress, and this did it with cells that are iPS cells, different type of cells, and highlights the potential of using this type of circular RNAs in therapy for future clinical applications. It is known that in cardiomyocyte, BCR1 can induce this circular insulin receptor locus upregulation that binds to another entity that is another protein, eventually leading to reduced mitochondrial fragmentation. So we're starting to learn how it is processed. So the mitochondria are protected, and therefore mitochondria, so important for the life of the cardiomyocyte, are no longer damaged by the anti-tumor drug doxorubicin treatment. This paper had also very interesting editorial by Tokgözoglu, where he was really highlighting that the idea that we know how the mechanism is taking place is also a new opportunity for the development of drugs towards this type of intervention. And my last paper is a paper that dwells onto something that is coming lately in the literature, and is the role of extracellular vesicles in cardiovascular disease. These are small blebs of cells that have a big potential for different issues, for being biomarkers, but also because they have crosstalk with all cells in the body, they can regulate functions. And this paper comes from the United States. It's a paper that comes from the Cedars-Sinai from Los Angeles and Baltimore and Johns Hopkins, and is an example of how biologists, cardiologists, and engineers can work together to develop future opportunities of treatment. The paper is first authored by Dawkins, and the title is Biological Substrate Modification Suppresses Ventricular Arrhythmias in a Porcine Model of Chronic Ischemic Cardiomyopathy. So the problem is ischemic cardiomyopathy, but what they are trying to reduce is ventricular tachyarrhythmias by using these extracellular vesicles. So these ventricular tachyarrhythmias often underlie hemodynamic collapse and sudden death. So while ablation is what is done usually to suppress these tachyarrhythmias, the efficacy is limited by major complication and also the exacerbation of heart failure. So the authors, what they did is to explore a complementary strategy. So rather than increasing the destroyment of the heart tissue, they propose to modify the substrate using antifibrotic exosomes secreted by cardiosphere-derived cells. So what they did is to use cardiosphere-derived cells from a human substrate and use them in pigs in which they had already induced ischemic cardiomyopathy. And this cardiosphere derives from these human cells were injected into zones in which they already detected delayed conduction around where the myocardial infarction had developed, produced the cardiomyopathy. 2 weeks after the use of this cardiosphere, the ability to induce ventricular arrhythmias was markedly suppressed when they were stimulating the heart. So the concept is that biological substrate modification may be an alternative and viable way to ablation to suppress these ventricular tachyarrhythmias. Obviously, this is also at the very beginning of the research process. These were cells that were healthy cells that were used, human cells, to produce this cardiosphere. And the cardiospheres were isolated, they had to be concentrated, and then used as a, let's say, kind of drug to be injected in the cardiac scar to improve this ventricular, the ventricular function. So I think that also this paper tells us of a third way in which the problems we have now in cardiology could be able to be solved in the future. As I say at the beginning, we are really happy to receive this type of work, although we publish with priority clinical papers, and my area of interest is ischemic heart disease, and we have very good papers in ischemic heart disease. I think that these translational papers as a source of ideas, hypotheses, and explain pathophysiology that can be of interest for future developments at the clinical arena. So these are my 3 papers. I don't know if you want to ask any questions. I understand that they are far away for many of you of the everyday work, but I think that it's important to consider that those unmet clinical needs we have can be solved in the future with these new approaches and new technologies, and to understanding better immunology, how immunology works in the different stages of cardiac disease development, using novel technologies based on our understanding of the RNA. And the third, using these extracellular vesicles that were considered debris years ago, and that now we are understanding that can have a use for detecting diseases via biomarkers, or even for understanding cell-to-cell crosstalk and disease progression.
Thank you, Lina. Brilliant selection of papers, and you're absolutely right. Our mission is not only to build the present of cardiovascular medicine, but also the future of cardiovascular medicine. And the identification of new therapeutic targets is part of the future, which can become really very close with the passage of time. And in particular, I found this circular RNA approach very, very interesting, because again, it's actionable, it's something which can be really translated into treatment in a foreseeable future. And also the topic is interesting because the growing interest in cardio-oncology is something we all have very clear in our mind. I read the question from the audience, Dr. Well, I cannot find his name now, but the question is about what about glyphosine in
the regeneration paper, the one of adult T cells. This is Dolexi, Teresa Dolexi, and the last author is Werner Haubner.
Oh no, okay, no. My question is, this is a question I read from one of our colleagues. Is Dr. Ramadan again? The question is about glyphosines in cardio-oncology. Glyphosine to prevent heart failure in cardio-oncology. You and Cecilia, anything?
Yeah, I'm just thinking about the Prada trial and how long it took actually to see if you can prevent other chemo-induced cardiotoxicity. I think, yes, we are on our way, and it may well be that the SGLT2 inhibitors also can help, and that should be subject of a study, I think, but we don't know for now.
This is unknown at the present, but the paper has another, let's say, view, because what happens with cardiotoxicity or drugs that induce cardiotoxicity or any kind of toxicity, they modify the RNA. They modify the genetic machinery, and therefore working on this type of circular RNA is a way of preventing damage. You see, so I think this is the first of many papers that will come in the future, trying to understand how these anti-tumor drugs are affecting the genetic machinery of the cells and produce the advancement of the disease. In our area of interest is cardiovascular, but it may be others where there are processes associated to damage to the genetic machinery of the cells. It's interesting because, as you very well know, and it was explained before with inclisiran and all these new drugs, there are plenty of, or the LPA, little a interventions that are using already the understanding that we have on RNA, and signals of RNAs are being used already in clinical trials. So they are advancing pretty fast. So as far as we have solid evidence coming from these very translational and initial studies, the development will be fast. So I think this is very important for the future of treating these cardiology patients that have also oncological problems.
Thank you, Lina. This has been the longest dialogue ever. It's more than 1 hour, but it's longer because it's been really fascinating. But before closing, I have a short question and short answers from all of you. What about your experience as editor of the European Journal? Lale.
It has been intellectually very stimulating, and I feel privileged to be working with top scientists. And I think we all know how laborious it is to produce a paper. So we do our best to be fair. And because we're all from different disciplines of cardiology, we look at different perspectives of the paper. And I think we learn a lot from each other. At least I've learned a lot. So I truly enjoy it.
Thank you, Lale. Anne, your comments.
I can second what Lale said, and I'd like to add, I think it's very inspiring actually to participate in our weekly meetings, and very pleasant. And part of the pleasantness is the team, of course, but also you, the way you conduct it.
Thank you, Anne. It's very kind of you. Cecilia.
Yeah, I would just like to say the same. I really enjoyed. I feel like a pupil going to school every time there is an editorial board, because we all have our little niches where we know the subject very well, but then to be comprehensive and grasp the entire field of cardiovascular research, that's a totally different thing. So I learn from the others. I enjoy very much being part of it. And I do dedicate quite a lot of time to the journal and enjoy it. Thank you.
Thank you, Cecilia. Lina, last word.
Yeah, well, I should say the same. It's a learning experience. It's very nice, but it's a lot of work. I mean, dear friends and colleagues that you are out there, I have to tell you that we have a lot of work every week, but we enjoy it. It's fun. I think this is what is important, and we learn. So it's a pleasure. And I would like to ask you something, Filippo. Maybe you can tell us of the novelties of how you see the future of the journal, because this will be also very interesting for the audience and for us. I mean, do you have any strategies, anything that you want to tell us here?
Well, this will remain a secret for some time, because we'll take another dialogue to explore what are the future avenues we are going to pursue. Today, I'd like to conclude with two remarks. The first remark is that I am really lucky to be surrounded by such a wonderful editorial board. It's the largest editorial board ever for the European Journal. And it is a wonderful experience because the commitment of the editorial board is incredible. And also the atmosphere is very pleasant. Please note that the editorial board is not made of women only. There are also some men in the editorial board. So this is the first remark. I'm really lucky to be surrounded by such a wonderful company. And we know that it's not time for soloists any longer. Teamwork is extremely important. And the success of the European Journal is mainly based on this teamwork. And the second remark is that I'm also happy because I think we are fulfilling our mission. And our mission is not only to publish top science, but also to create empathy among editors, reviewers, authors, and cardiologists at large. And dialogues like today are a good example of how this empathy can be created. I think it is important to generate this empathy because our final goal is to reduce the burden of cardiovascular disease. And this is reduced again by publishing not only top science, but also by creating a pleasant atmosphere which encourages the utilization, the best possible utilization of our knowledge. So this is my last remark for today. Thank you again, Lale, and Lina, and Cecilia for this wonderful hour, more than 1 hour, almost 1 hour, 15 minutes spent together, but this is not a Congress. So time is not as oppressive as it is during Congress. We can be a bit more relaxed. And we also close to the end of the year, and I wish all of you, editors, colleagues, all those present in the audience today, I really wish you a happy new year. We come from a terrible experience of 2 years of COVID, and we all hope that the future will be brilliant. I'm optimistic by nature. I'm sure this will be the case. A wonderful future for the European Heart Journal, for cardiology and for cardiologists, and for humankind at large. Thank you again, and we will meet again for the dialogue on the last Thursday of January, which will be the 26th at 17 Central European Time. Thank you again to all of you. Bye-bye.
Thank you.
Happy New Year.
Happy New Year.
Bye.
A lot of champagne or Prosecco or Cava tonight.
Bye-bye.
Thank you everyone for joining, and have a lovely day.